Today, we're going to discuss the role of denosumab in the management of giant cell tumor of bone. In this lecture, I'm going to discuss the normal bone resorption cycle, the effect of tumor on the bone resorption, how does the tumor cause bone resorption, and what is denosumab and how does it interfere with the bone resorption cycle. Then we're going to discuss what is giant cell tumor regarding the pathology and the radiology and what the conventional treatment for it is. And then how could we fit denosumab in the treatment of giant cell tumor? How do we use it in treating this tumor? What is the methods of administration of denosumab and how do we assess the response? And what are the common side effects of using denosumab? And what do we do if the tumor recurs after we stop treating giant cell tumor with denosumab? Then I'll finally present two cases from our series of giant cell tumor that were treated by denosumab. And at the end of the lecture, I'll show an algorithm of how do we treat giant cell tumor and how we incorporate denosumab in its treatment. So first, we're going to talk about the key player in the bone resorption cycle, which is osteoclasts. As you see here, osteoclast is the rounded gray figure. It has what we call rank on it. Rank is a receptor-activated nuclear factor kappa, and we see it here like a horseshoe, like a lock. On the other hand, rank ligand is a protein produced by the osteoblast that has a circle that fits into the lock. So the rank is the lock, whereas the rank ligand is the key. And once the key gets into the lock, the cell will be activated. Osteoprotegerin, on the other hand, is a protein produced by the osteocytes and bone lining cells that prevents the rank ligand from locking into the rank, thus disrupting the bone resorption cycle. You can see here in the diagram that I got from the internet, here's the osteoblast that produces the rank ligand, the key, and the rank ligand will activate the osteoclast precursor and transforms it into an active osteoclast. So the rank ligand will go to the rank on the osteoclast precursor to activate it, and also can go directly to the osteoclast and causes its activation to cause bone resorption. This process of bone resorption, which entails the osteoblasts, the osteocytes, and the osteoclasts, is heavily regulated in the body. There are hormones, there are cytokines, there are diseases that inhibit or accelerates this bone resorption cycle. For example, parathormones stimulates the osteoblast to produce more rank ligand and hence enhances bone resorption. Whereas estrogen, for example, it inhibits the rank ligand production, thus inhibits bone resorption. And once the estrogen drops after menopause, then the bone resorption just increases. So what is denosumab? Denosumab is a monoclonal antibody that is produced in the lab that is directed towards the rank ligand. So once it binds to the rank ligand, it will disrupt the bone resorption as it prevents the rank ligand from going to the rank. You can see here that the osteoblast produces the rank ligand that is supposed to activate the osteoclast, but the denosumab, which is horseshoe shaped like this, binds to the rank ligand, thus preventing it from reaching the receptor on the osteoclast and the osteoclast precursor, that it inhibits the transformation of a pre-osteoclast into an osteoclast, and it inhibits the activation of the osteoclast, thus inhibiting the bone resorption. So actually, the denosumab acts similar to the osteoprotegerin, but the denosumab is produced in the lab, directly binding to the rank ligand. So what is giant cell tumor? Giant cell tumor is an intramedullary bone tumor composed of mononucleated cells and osteoclast-like multinucleated cells. It has an unpredictable potential for growth. The behavior is a benign tumor, rarely metastasizes, and it has a high incidence of local recurrence if it's not treated properly. If you look at the pathology of giant cell tumor, it's composed of three types of cells: the stromal mononuclear spindle-shaped cells, which are similar to fibroblasts and possibly undergoes osteoblastic differentiation. That's why these cells actually can produce rank ligand like the osteoblast does. And there are the round mononuclear cells that expresses monocyte macrophage markers. And there is the multinucleated giant cells, which are similar to osteoclasts. Why do we say that they're similar to osteoclasts? Even in the past, they used to think that they are osteoclast, and giant cell tumor was wrongly named as an osteoclastoma. But they're not actually osteoclasts, but they're similar to osteoclasts. Similar in what? They express tartrate-resistant acid phosphatase and cathepsins, which are needed for bone resorption. They expresses the rank receptor, similar to osteoclast, and they have an infolding border with numerous centrally located nuclei, similar to the osteoclast, but they're much more than the osteoclast. There are hundreds of nuclei, which is more than what we find in the osteoclast. And if you look at these giant cells, they appear to be a synthetium of the stromal cells. It's as if the stromal cells has fused to make the multinucleated giant cells. The nuclei of the giant cells are similar to the nuclei of the stromal mononuclear cells. So as you can see here from the pathology of the giant cell tumor, that these cells are similar to the bone cells that are responsible for bone resorption, but these are located in a certain area of bone, and they cause bone resorption in the area which is affected, but using the same mechanism that is used by the osteoblast and osteoclast that we talked about earlier. This is how the giant cell tumor looked. This is the giant cells with hundreds of nuclei in the middle, and here are the stromal cells around it. You can see here another view of the pathology of giant cell tumor. We don't need to go into the details, but whoever is interested, this is a paper done by Robert Cohen and Gurmeet Singh, and they explain in details how the cells of giant cell tumor interact to cause tumor proliferation and bone resorption, similar to what happens in the normal bone resorption cycle. So from this, we can conclude that the monoclonal antibody, the denosumab, it inhibits the normal bone resorption cycle, but it also inhibits the bone resorption that is caused by tumors such as giant cell tumor. Bone resorption by the giant cells and by the osteoclast is caused by the cathepsin K, which degrades the organic component of bone, and the V-ATPase, which demineralizes the hydroxyapatite. And it also produces the TRAP, the tartrate-resistant acid phosphatase, which dephosphorylates the bone matrix protein and assists in osteoclast migration. These are the things that are produced by osteoclast to cause bone resorption. This is how a giant cell tumor looks like. It's osteolytic, well-defined border, eccentric, that could occur in long bones in the epiphyseal area or epiphysiometaphyseal area. It could be small and well-defined like this X-ray. It could affect small bones like here, giant cell tumor of the talus. And it could be very aggressive, causing complete washout of the bone like we see here in this giant cell tumor of the proximal tibia. The conventional treatment of giant cell tumor is extended curettage. What we mean by extended curettage is curetting using a high-speed burr and using an adjuvant to decrease the incidence of recurrence. This adjuvant could be phenol, could be cryo, could be the heat that is produced from the cement. In extensive cases and in expandable bones, we do resection of the bone and replacement if required by one of the reconstructive methods. You can see here giant cell tumor of the distal femur and treated by extended curettage and filling it with bone cement. Whereas in such a case with extensive giant cell tumor of the proximal tibia that is not reconstructible by extended curettage, we do resection and reconstruction with a modular prosthesis like we see here. So how could denosumab fit in the treatment of giant cell tumor? Since the classic treatment is either curettage if the bone is reconstructible, or resection when the giant cell tumor is extensive. Well, actually, denosumab has several roles in treatment of giant cell tumor. We'll explain each one individually. It could be used as the neoadjuvant treatment. You see a patient with a giant cell tumor that is aggressive, you give him denosumab, then instead of doing resection, then the bone forms and you can do a curettage instead. So you do a less destructive surgery because you gave him denosumab up front. So it's the advantage, it could downstage the tumor. However, the disadvantage of using it as a neoadjuvant treatment is that it transforms the bone into fibrous tissue, which makes curettage later on very difficult. You can easily curette giant cell tumor because it's friable, but once you give it denosumab, it's transformed from this friable constituency into a fibrous tissue, which is difficult to curette and could make local recurrence, ironically, more than the expected. Or you can use denosumab as an adjuvant. You do your curettage and then you give denosumab to decrease the local recurrence. However, using it as an adjuvant is not an established form of treatment. Nobody ever proved that giving denosumab following curettage would decrease the incidence of recurrence. The third way that we can use denosumab is to use it with a curative intent, like extensive lesions in the sacrum or pelvis, that you want to cure it just by giving it denosumab without the need for surgery. So the advantage is that there is no surgical morbidity. However, the outcome is unpredictable because you don't know when you're going to stop. You can just keep on giving denosumab, but once you stop, maybe the tumor would recur. Or you can use it as a palliative measure in patients that it's considered one of the least morbid solutions and surgery would not be possible. However, still, as the previous treatment option, it has side effects from the prolonged use. It's an expensive form of treatment that the patient keeps on paying for a long period of time. So either denosumab could be used as a neoadjuvant, which is the most common form of strategy, or adjuvant or curative in non-operative cases. So how do we give denosumab? Denosumab is given as a subcutaneous injection. There are two forms, one which is 60 milligrams that is given for osteoporotic patients, which is called Prolia, and there is the Xgeva, which is 120 milligrams per injection, which is used in treating giant cell tumor. It's given every 4 weeks. However, the first month, we give loading dose at day 1, 8, and 15. So once you start using Denosumab, you give them at day 1, 8, 15, and then on monthly basis. However, prior to giving the injection, we have to assess the calcium level, make sure that it's normal, and you have to give supplement calcium and vitamin D after the injection. We usually prefer that the oncologist gives the Denosumab to the patient. We don't give it as an orthopedic surgeon, and the patient doesn't take it at home. We prefer that it's given under the supervision of the oncologist. So how do we know that the Denosumab that we're giving is effective? Actually, it's effective in 86% of patients, as was done in a phase 2 study. And the response is assessed clinically, radiologically, and pathologically. Clinically, the patient feels that the pain decreases. If he has neurological symptoms, like in sacral giant cell tumor, the neurologic symptoms decreases. If it's in an accessible site, you feel that the tumor becomes more firm than cystic. Radiologically, an X-ray shows a peripheral bone rim forms. There is inside sclerosis. If you do a PET scan, you'll find a lower SUV. And if you do DEXA, you'll find more BMD. If you take a biopsy from a giant cell tumor after being treated with Denosumab, you'll find decrease in 90% of the giant cells and decrease in stromal cells and more fibrous osseous stroma. You can see here to the left, this is a giant cell tumor prior to treatment, and this is after treatment. You see that the cells decreased in size, decreased in number. The giant cell tumor became sparse. However, more fibrous stroma in between. So what are the common side effects for Denosumab? They obviously cause hypocalcemia and hypophosphatemia. That's why we have to make sure before giving Denosumab that the calcium level is normal. They could cause bone cramps, generalized bone and joint pain, nausea, diarrhea, or constipation, teeth loosening, swollen gums, and even osteonecrosis of the jaw, which happens in 2% of patients. They could cause delayed bone healing and pathological fracture. And when you stop it after using it for some time, it could cause rebound hypercalcemia. And very rare reports on sarcomatous formation. And this has been a very debatable issue, whether using Denosumab for a long period of time could cause the giant cell tumor to be sarcomatous. Once we stop Denosumab after using it for a while, it is possible that the tumor will recur and will regrow again. Usually this happens in after 7 to 9 months of stoppage. Why does this happen? Because actually Denosumab does not kill the cells. It rather inhibits the cells and inhibits the bone resorption, but the cells are still there. Various reporters tried to explain why this happens. Mack et al. Said that there is persistent tumor cells in the peripheral bone growing at a slower pace. Lau et al. Says that there is no apoptosis, but rather inhibition of cells. But it's expected that after stoppage of Denosumab that the tumor will recur after a while again. So what do we do if we're giving it with a curative intent or in sacral lesions or extensive pelvic lesions? How do we do this? We actually have to balance the effects versus the side effects. We keep on giving Denosumab, and if side effects occur, we have to stop it, either temporarily or permanently. After a while, we give drug holidays. Instead of giving the drug monthly, we start to giving it every 3 months or every 6 months and monitor how the tumor responds. We monitor this by CTs and X-rays. We see if there is any recurrence of tumor or not, If it's not recurring and if it's stationary, we keep our frequency of denosumab. If it recurs, then we re-give denosumab and resume the original frequency. A CT is better to monitor the bone formation than using MRI. Some physicians who monitor the progress of denosumab by measuring the markers of bone turnover, like urinary N-telopeptide and serum C telopeptide and TRAP. The effect of denosumab on metastatic giant cell tumor or on pulmonary metastasis is actually unpredictable. These metastases could remain stationary, they could regress, or they could even progress. And in some cases, we've seen mixed response. Like some of these pulmonary nodules might disappear, and at the same time, others would appear. And there is no explanation for that. However, in the majority of cases, giving denosumab for metastatic giant cell tumor has been very useful. Finally, I'd like to show two examples from our series at Cairo University. The first is a male patient, 22 years, who presented to us with a giant cell tumor of the sacrum. This was in 2010. He was started on denosumab treatment. This is his MRI after 2 years, and this is his MRI after 4 years of post-treatment. This patient actually has been a long-term remission following denosumab. He is now 10 years with no regrowth of his tumor. And this is his final X-ray with bone formation in the sacral tumor. This is the second example of a female, 27 years, with extensive giant cell tumor of the pelvis. We did pre-embolization of her tumor and then started her on denosumab after doing curettage. And you can see here the bone formation with denosumab. And this is her CT showing the bone formation. She walks with a limp, and she goes on drug holidays for several months and then resumes the denosumab whenever the tumor starts to grow again. She's now about 5 years post treatment with on and off treatment with denosumab. However, she's a walker and she's resuming her life. This is my final slide to show our algorithm in treating giant cell tumor in general. For stage 1, 2, and 3 with an intact joint, we do extended curettage. Unless it's an expandable wound like the proximal fibula or distal ulna, we do resection. In stage 3 of giant cell tumor with a destroyed joint that is not amiable for curettage, we do resection. In certain pelvic locations, we do resection and reconstruction of the defect. We could use denosumab as a neoadjuvant to make resection easier. In sacral lesions and huge pelvic lesions that are inoperable and operation carries a high morbidity, and in metastatic giant cell tumor, we use denosumab plus or minus embolization and plus or minus radiotherapy, depending on how it responds to denosumab. Thank you very much for listening and waiting for your comments. أتمنى أن يكون الفيديو ده كان مفيد ليكم، وفي انتظار تعليقاتكم وأي كومنتس أو استفسارات، وإن شاء الله أقدر أرد عليها في أقرب فرصة ممكنة. وإلى اللقاء في فيديو آخر إن شاء الله يتعلق بأورام العظام.